Hi guys, welcome back to the Chronic Chronicles. I'm your host, Lexi Halloran. Today we're talking with Dr. Jeff Arrington, a highly respected endometriosis surgeon, known for his expertise in excision surgery and compassionate care for patients. Together, we will explore what makes excision surgery the gold standard, the myths and misconceptions around surgical options, and really how a patient-centered approach can transform lives. Let's get started. To start out, can you give us a brief introduction on who you are and what you do?
Yeah. So name is Jeff Arrington. I'm a GYN surgeon, trained in minimally invasive surgery. I did a fellowship way back in the day when I think the number of fellowships offered were only 13. I think now there's over like 50. There's a bunch of them now. I finished that fellowship in 2005. I trained under Dr. C.Y. Liu in Chattanooga. That fellowship was primarily like a pelvic prolapse fellowship.
Okay.
He is definitely one of the pioneers of laparoscopy, and we did a lot of good endometriosis work as well. So after that fellowship, I moved back to Utah. I was born and raised in Utah, moved back, and I was just in a general OBGYN practice for 14 years, delivering babies, doing surgery. I did a lot of, one of the few surgeons way back then that was doing laparoscopic, laparoscopic work. Did that for 14 years. And then just before it was 12 about 12 years in, I ended up dropping the obstetric side of things because the surgery volume and the surgery need got so big.
Yeah.
And about a year after dropping the delivering babies, the endometriosis need was so high that I actually started moving or sending a lot of the patients just for like routine hysterectomies and bladder incontinence slings, those sorts of things. My partners, so that I could focus just on providing time and surgical treatments for endometriosis patients. So since 2017, I've been doing advanced laparoscopy for endometriosis for nearly 20 years, only doing endometriosis surgery since 2017.
Wow. Yeah. That's really impressive. So, and you went to medical school in Wisconsin, right?
Yes. Yep, Medical College of Wisconsin.
Okay, cool. I'm from the Midwest. I'm from Michigan, and I went to grad school in Wisconsin too. So
What
it's a
school
fun
are you
place.
at?
For grad school, I went to University of Wisconsin,
Okay.
Madison. Yeah.
Okay.
It's a fun place. Lots of cheese curds.
Lots of cheese curds, very cold winters. I tell everybody it would snow in October, and that same snow would still be on the ground in April.
Yep. I know I went to undergrad in the Upper Peninsula at Michigan
Oh,
Tech, so
yeah,
we would have snow until
yeah.
June. It was
You're
ridiculous.
you're a Youper. We call
hmm
it Youper.
Yeah. Okay, so you have been specialized in endo since 2017. That's a pretty long time. I mean, you kind of already said, but like, why did you choose to specialize in endo? Did you just see a need for more or?
That's part of it. I mean, coming out of the fellowship, I just wanted to be able to offer, minimally invasive laparoscopic options for everything.
Mhm.
I'd been taught the endometriosis work, really was in love with it at that point. But as time went on, I think the thing that drew me to it, not only the need, because there's like nobody in Utah at that point that was doing anything anywhere close to what I would consider top level endometriosis care, really kind of in the Rocky Mountain West, but the challenge of it too.
Mhm.
Surgically as a doctor professionally, just the idea that every patient and every surgery can be different than every other one. And the variety of things that are involved. I like that I get to do some general surgery work. I like that I get to do some urology work, all those sorts of things that, typical GYNs just don't get to do or aren't trained to do. That really, it's just become fun to me.
Yeah, I mean, I can imagine. I've seen some videos and pictures of endo surgeries, and it's kind of like I, to a blind eye, I'm like, how do you guys even know where, like, what endo is? It's crazy. And I've heard from other doctors where they're like, sometimes you don't really know if it's endo or not. You're just kind of like, it looked weird, so I
Yeah,
took it out.
yeah. And you never know if it's endo unless you do.
Mm-hmm.
And that's really the way that I approach, any endosurgeries. I go in and I do a lot of comparison what tissue should look like,
Mm-hmm.
but also comparing a certain area to everything around it. And if something does look different, it has the possibility of being endo. You'll never know if it's endo unless you remove it and test it.
Yeah, that makes a lot of sense. And by the time people are coming to you, do they already have endometriosis diagnoses?
No,
Or okay.
it's a smattering of everything. Some are still young, but they have family or friends around them that kind of point them in the direction. And
Mm-hmm.
then they do their own research. They don't have a formal diagnosis. Other ones have been on hormones for years, not getting, where they want to be, and they don't have a formal diagnosis. And then
Yeah.
you get some that already have it and either have recurring symptoms. So they've had one surgery, they have recurring symptoms, or the disease is severe enough that they're either referred or they look for other options, beyond what they're typically told.
Okay. And then you do mostly excision surgeries with the robot, correct?
Yeah, pretty much 100% robotic, an
Okay.
excision approach. There are a number of different ways that people will cut the endo out. Some cut with lasers. I cut with electricity. So I basically just have scissors.
Mm-hmm.
But instead of cutting with the scissors, I shoot electricity through the end of the scissors. So it's almost like cutting with a little teeny lightning bolt.
Oh, that's
Super
cool.
precise, has a little bit of bleeding control with it. Some people use like mechanical energy tools, a variety of different ways to do it, but the goal of all of them is to cut the disease out.
Okay. Do you do any ablations?
There are limited times when I do.
Okay.
Those typically come in patients that want to be where fertility is the highest priority or keeping organs is the highest priority.
Mm-hmm.
So if I see endometriosis on, say, over a blood vessel feeding an ovary, and the patient has not consented for removal of the ovary, or doesn't want it removed,
Mm-hmm.
I will first try to remove that endometriosis to see if we can safely get it separated away. But if we can't, and the highest priority is maintaining fertility, those are the times where I'll back off and treat those areas more conservatively and
Okay.
then, do the excision in other places. We're making a patient-driven decision to prioritize fertility over endometriosis. Does that make sense?
Yeah, that makes a lot of sense. Follow-up question. So on TikTok, which is not a great, I talk a lot on this podcast about how there's just like so much misinformation on social media, and there's good information too, but I've seen a lot recently on TikTok where people are really like bashing ablation and saying that it creates more scar tissue and it is not good for fertility. Is that necessarily true?
So anything that causes inflammation can cause scarring.
Mm-hmm.
Whether it's prior surgery, whether it's endometriosis is inflammatory, whether it's a pelvic infection, cutting tissue results in inflammation.
Mm-hmm.
Burning tissue results in inflammation. Separating, if tissues are stuck together, separating them results in inflammation. And part of that inflammation is how what the body uses to repair itself.
Yeah.
But it also has the potential of generating adhesions and causing scarring. The concern that I see with ablation is that very often results in incomplete treatment of the disease. So in cases where they go in and do ablation, not only do we have now a surgical insult creating inflammation,
Mm-hmm.
if we have untreated disease, we still have the tissue-related inflammation. And that combination of surgical inflammation and tissue inflammation often results in worse adhesions than what the patient started with.
Gotcha. Okay. So sometimes you do use ablation, but it's more so you're doing it in a combination with excision.
Yep, and that's something that we discuss with patients ahead of time, so they're aware, when fertility is the highest priority, and based on the ultrasound, we suspect that it's going to be a more severe case. That's a discussion that we have, and so
Okay.
the patient can make a conscious, basically priority decision on what they're looking for.
Mm-hmm. Yeah, that makes a lot of sense. Gosh, I know we're talking and I'm like thinking about my own treatment too. I have stage 4 endo, and I've had one surgery, which was an ablation, but that was done in the UP in the Upper Peninsula. We did not have specialized surgeons. And yeah, that was 7 years ago. And now I've been looking, I live in Seattle now, so I'm trying to find a specialist here for an excision. I've been going back and forth with like my normal OBG, and she's like, well, we could do another ablation. And I'm like, I just
Yeah.
didn't get much relief from it. I'm like, I don't think that's
Yeah.
the way to go.
There's some good options up that neck of the woods, though. Gig Harbor and Portland, you've got some pretty good options up your way.
Yeah, there's a lot more, for sure, a lot more than there was in the Upper Peninsula. How often do you recommend surgery? I mean, you're a surgeon, so I feel like you probably recommend surgeries fairly often.
I rarely make a recommendation.
Okay.
I look at my role when a patient comes in for consult or we talk about things, review things. Number one, we look at as much as we can, the possibility or probability of having endo.
Okay.
We look at the history. When I have the chance to, I really like to do my dynamic ultrasound or ultrasound staging for endometriosis, just to give the patient an idea of what they're looking at, what we think the insides are doing.
Okay.
And so I look at my role as an educator, and then we talk about the options, and every patient gets the options of observation, what we call palliation or symptom control with, hormones, medications, control of symptoms, and surgery. And we talk about the pros and cons of that, the things they need to think about going forward. There certainly a risk to surgery, but in endometriosis, there are also risks to not doing anything and risks to just focusing on symptom control. So I look at my role as an educator to give them that information, and then the patient gets to decide.
This is such a hard question to answer because endo is so different in everybody. But what would you say is kind of like the best treatment plan in your opinion why don't we say, like, I don't know, I guess I'll just like give you me, because that is like somebody like me. So like mid-20s, wants to preserve fertility, has already had a surgery, knows they have endo. Like what then? Do you do another surgery? Do you do like a combo?
So the first thing I would want, so the two issues that most patients are concerned about, not every patient, but most patients are concerned about with endo. Number one is the pain and how they feel.
Yeah.
Number two, like in your case, would be fertility going down the road. So too often in endometriosis, and especially in the studies looking at younger patients, the focus is very heavily on symptom control. That they just figure, if we just control your symptoms, then if and when you want to get pregnant, we'll address that when that time comes. Problem is, many patients, they get 8 to 10 years down the road and they're ready for that, and then all of a sudden they find out that their endo is destructive.
Yeah.
It's completely been game-changing and life-changing, and where it could have been very easily treated early on. So, someone with your history, the first thing I would want to do, again, is use that dynamic ultrasound to see if we can stage it. To get an idea, even though we may think that there's deep endo, if the organs are relatively free, if there's no big ovarian cysts, if the tubes aren't stuck, if the bowel's not stuck to the, uterus, those sorts of things. If we can get an idea of what the endometriosis is doing inside, then we can use that to try to help figure out where a patient is. If the pain is minimal, I just had one yesterday. The pain is fairly minimal, but she's concerned about fertility going forward. We did the ultrasound and really found things to be pretty free, but we know there's endometriosis based off her prior surgical history. Right now it looks like, if she does have endometriosis, it's going to be stage 1 to stage 2. And I'll have some patients like this one that decided, I just want to be done with it and not have to worry about it progressing. And then I'll have others say, as long as it doesn't look destructive, I'm managing okay with whatever medicines they're taking now, and they're okay with that.
Yeah.
And they choose to just do observation. But with that now, with the ultrasound use, instead of really not having any idea going forward what the disease is doing, I can bring those patients back every year or two and do a repeat ultrasound and monitor for any progression of disease. So, even in your case, depending on how bad the symptoms are affecting you, if we can be relatively assured that there's not really organ destruction, some patients will choose to do observation with the ultrasound surveillance, and some will choose to move forward with surgery.
Yeah. So with the ultrasound, you're looking at organs and trying to figure out if they're stuck together from
Yeah.
the ultrasound?
Yeah. So
Okay.
it's a typical, vaginal ultrasound,
Hmm.
regular ultrasound. Most of the time when they do those, they look at the uterus, they look at the ovaries, they may look at the bladder, they look to see if there's any cysts, and that's really the extent of a normal ultrasound.
Yeah.
But with the ultrasound, we can see, when we're looking at the bladder, we can see thickening in the bladder wall or nodules in the bladder wall. We can look at and follow the muscle of the colon and the lower colon and the rectum and look for any thickening there. One of the big things with ultrasound is the dynamic aspect of it. So during ultrasound, everything is live and we can actually watch the organs and the tissues move.
Yeah.
Typically, an ovary that's sitting in the pelvis, it should move separately from the uterus. It should move separately from the pelvic sidewall. So as we put gentle pressure on that ultrasound and move things around, if the ovary moves together with the pelvic sidewall, I know that the ovary is stuck, and that raises the suspicion of a higher stage of endometriosis. Or if the bowel is
Got
stuck
it.
to the back of the cervix or the back of the uterus, that again tells us that this patient at least has an obliterated cul-de-sac, possibly frozen pelvis. So we can get all that information with ultrasound now before surgery ever happens. So, and really, as ultrasound becomes more prevalent, which I think it needs to,
Yeah.
we can really end these cases where I was taught to call them peek and shrieks, where the doctors go in, they have no idea what they're getting into, and get the camera in and realize that it is way beyond their skill level. With the ultrasound, we just don't run into that anymore.
Well, and I think that, again, like I'm speaking for my case, like years ago, I genuinely had my surgeon tell me, she was like, she did my surgery and she came out and she was like, yeah, I diagnosed you with stage 4 endo and I got what I could, but like, you will probably need surgery again. Like, I couldn't get
Yeah,
most of it. And then she also referred me to a specialist at U of M, but that was like a 10-hour drive. And I'm like, can we just try other things like
yeah,
outside of
yeah,
surgery? So, but yeah, that's well, not the cool thing, but I guess kind of the cool thing with endo too is that you may get diagnosed with a stage, but it can change too. It's not, sometimes people, what I found, they get really stuck on like whatever stage they're on, but it's kind of like a moving thing.
yeah.
You're not always in that.
Yeah, and honestly, to me, staging, somebody tells me I'm stage this or stage that. I don't know a lot to do with that. Number one, it's more informative to me to say this is where endo was found, or that, these things were stuck together. This is where endo is, rather than just saying, oh, I'm a stage 3 or stage 4. Interestingly, too, I mean, I've seen patients over the year where they've been told they're stage 3 and stage 4, and I review their images and they're a 1 or 2.
Yeah.
Oh, there was one I remember way back reading the operative report, and the doctor said that they had just scattered lesions of endo on the surface, but then she had one teeny little lesion on the surface of the colon, and dictated in the report was, this makes her a stage 4. When it doesn't, because
Yeah.
even that teeny little bit of endo probably still keeps her, because it was so small and on the surface, probably still keeps her at a level 2, or a level 1, maybe a level 2.
Yeah.
And patients can have superficial endometriosis over the entire pelvic lining. But if the ovaries aren't involved, if there's no adhesions, if there's no deep disease, it's still a stage 1 disease. So the actual description of it is far more valuable than just stage this or stage that.
Yeah. I feel like people have different definitions of it too, which is kind of weird because there shouldn't be, but it looks different. I don't know.
Yeah, and for years and years, we used one that was done out of, I think it's called ASRM. It was more of a fertility-based score. So it didn't
Okay.
focus on where the disease was or what it was doing, but it focused a lot more about adhesions of the ovary, damage to the tubes, those sorts of things. The AGL came out with one a few years ago that actually looks at location and depth of the disease.
Yeah.
That's one where we have a classification of the peritoneum, we have bladder, we have the rectovaginal space, we have bowel, we have appendix, diaphragm.
Mm-hmm.
All those things are pulled in to try to get a more accurate staging of the disease and really what the staging means.
Okay. When you go in and say you are doing a diagnostic surgery, do you still use the staging, or do you have like what do your reports look like in
I
that?
mean, the reports are basically initially just a description of the findings, and then it goes detailed, how I look for it and the treatment of each individual area and what's involved. So usually my operative reports are anywhere typically from, a full page and a half up to 4 pages long. So
Wow.
so I do a lot of descriptive type of stuff rather than staging in
Mm-hmm.
the report. It's interesting that, I'll get reports from other doctors, and it's funny that they spend more time talking about the beginning of the surgery, how the patient is positioned, how they fill the belly up with the air, exactly how much air they put in, and how
Mm-hmm.
the trocars are put in. They'll spend like 2, 3 paragraphs talking about all this stuff, and then one short paragraph of the disease and treatment, and then done.
Yeah. And you're like, I need more about
There's
the
like
disease and the
zero
treatment.
helpful information in that.
How often do you have a patient where you do repeat surgeries? Because I feel like that would be really helpful to
Yeah.
have really good descriptions for when you go back in, then you can
Yeah,
see.
so yeah, really good descriptions, but even better than that is to give the patient a copy of the pictures of the surgery. I mean,
Yeah.
they say, pictures say 1,000 words, and it's absolutely true with
Hmm.
endometriosis. With pictures, well, combining pictures with pathology so we can see what was seen, what was treated or not treated,
Hmm.
but also look at the pathology of those things to compare. Did this have endo in it or was it negative? So going into a repeat surgery, that's good information to have because we can see areas that may be of concern, but we can use that information to, number one, gauge what we're looking at currently. But me as a surgeon, if I ever have a chance to go back in and do a second look, it's a valuable teaching tool to me too. Because
Hmm.
I can see, okay, this is what I saw before, this is what was treated, this is what was positive or negative. And when I go back in, if I find areas that are positive, I can compare that back to the original surgery and see if there's things that I can learn from how that was treated to try to do better in the future.
Okay.
It's not, reviewed and published data, that sort of thing. But when I was in Utah before, we went and looked back over an about 11-year period of time, pulled those patients. And back then I had access to the hospital system database. So we were able to pull patients that had a repeat surgery, not only with me, but any doctor within the network. And that
Okay.
repeat surgery rate was just shy, somewhere between 10 and 11%. From the published literature, that's a little bit low. The published literature, the most significant one recently was last year with Dr. Roman out of Europe. And their rates over a 5-year period were about, I think, 18 to 19%, somewhere in that ballpark. So
Yeah.
realistically, it's probably somewhere between 10 and 20% reoperation rate among the high-level endometriosis surgeons. My experience is we might find endo in about half of those.
If you've ever felt like you're battling your own body during a flare, you're definitely not alone. I feel like that all the time. And that's where Some Days comes in. They create products specifically designed for people who deal with chronic pain and period discomfort. Their cramp cream is my go to. I keep cramp creams literally everywhere in my car, in my purse, and in my nightstand, and in both of my bathrooms. So it's always within arm's reach whenever I need it. And if I even feel like the slightest cramp coming on, I immediately slap some cramp cream on. What's really nice about it is that you don't have to use it just for pelvic cramps or abdominal pain. You can use it for literally any muscle cramps you have. I like to use it a lot for my sciatica, like lower back pain as well. And what I really love most about Some Days is that they just really get it. Their products are plant based, and their mission is all about making painful days a little bit easier while being environmentally friendly. Did you know that they're B Corp certified? Check them out at somedays.com and use discount code Chronic Chronicles to save on your order. Their cramp cream would also be the perfect stocking stuffer for you or your loved one who has chronic pain.
At 80 to 90% of never having to have another surgery is far better than what patients are typically told for endosurgery.
Yeah, I mean, that is a way better like again, my surgeon 7 years ago was like, yeah, I give you like 2 or 3 years and you're gonna
Yeah.
be wanting another. And I mean, I did, and I've held off like 7 years, mostly because surgery is not easy. It's the recovery is hard. And then, like I go through and I read kind of like what we talked about. You get inflammation no matter what. So I'm like, okay, well, what, what's the
Yeah.
benefit here? What's not?
Yeah. The idea behind surgical inflammation too, though, is that's kind of a self-limited thing. It is certainly inflamed while the tissue is healing, but once the tissue is healed, the stimulus for that inflammation should be gone. And the interesting thing is usually in patients, if adhesions are going to form after surgery, they form within the first 7 to 10 days.
Oh, wow.
Whereas if it's endometriosis, I mean, that's a long-standing or long-term inflammatory condition that has the potential to generate adhesions at any point along the way.
Very true. Yeah. I mean, yeah, I'll not talk too much about myself. How widespread have you found endo? Like, what are the furthest organs, I guess, that you have found endometriosis on?
I mean, the furthest is going to be the lung.
Mm-hmm.
Typically I covered, the underside of the diaphragm all the way down to the pelvis. So we found it on the diaphragm. Occasionally, it's kind of expanded from the diaphragm into the liver, and then really all the way to the pelvic floor.
That's crazy. It's everywhere.
Small bowel, large
Yeah.
bowel, appendix, bladder, ureters. I know Dr. Sinerva, when I was in Georgia at one point, they had a patient that had it in the pancreas. So that was a big kind of 3 or 4 surgeon complex
Mm-hmm.
case.
Is there the possibility that, if endo is growing on other organs like your pancreas or something like that, that it could affect the organ's function?
Oh,
Like,
yeah.
yeah.
Yeah,
Okay.
I mean, pancreas is going to be super, super, super rare.
Oh, for sure.
Super rare. But I mean, if there's stuff growing in the pancreas is basically, it's a producer of enzymes.
Mm-hmm.
And so if the pancreas gets inflamed and the cells start to release all of their enzymes, it can be incredibly painful and destructive. If it's growing around the ducts that carry the enzymes into the gut, it starts to block those off. It can really cause a lot of damage that way. From a bowel standpoint, the main thing we run into is obstruction. If the nodules are big enough, deep enough that it can obstruct the passage of the stool and cause a backup. I've seen a handful of cases where patients have had kidney damage because their ureters get compressed and shut off, and the urine backs up the kidney and knocks the kidney off. So it definitely can.
Yeah. I think that, I mean, that's important for like the greater community to hear because, people with endometriosis, I mean, me specifically, it's like an uphill battle to explain to people around me that it's like not just, or not even a period disorder, that it's not, like just affecting your reproductive organs.
Yeah.
And like one of my biggest symptoms recently is that I have to pee every hour and a half. And it's been like that for like the past year, and I've gone to the doctor and everything's fine. Like I have no UTIs, I have nothing like that. But my doctor right now is like, yeah, you probably have like inflammation or endo around your bladder or something that's making.
Yeah, I mean, one of the common things that we see that fairly commonly in patients with endo, and there's a condition called interstitial cystitis that's a bladder irritative condition that gives that symptom. But there's also some potential nerve theory behind it too. One of the more common areas that we find endometriosis is around the uterosacral ligaments around the pelvic sidewalls.
Okay.
And right underneath that ligament, there's a nerve that passes through called the hypogastric nerve, and that nerve carries branches to the bladder. Well, in theory, if there's endometriosis around that area, if it's triggering the nerve, patients will often feel, either bladder symptoms, bowel symptoms. So in that sense, that it could be related to endo as well.
Yeah. Well, I just think it's like we were on a road trip the other day with our friends and we had to stop to go to the bathroom like frequently. And they're like, oh my gosh, Lexi, you're 27. Like, why do you have to pee so much? And I'm like, I don't know. This is
Yeah,
a relatively newer thing for me. I'm like, it's pretty annoying though, I will say. But
yeah,
it's not painful or anything. And sometimes it's kind of annoying because I actually like, it's not even like a full bladder, but I just feel like I am. And I'm like, okay, well, I have to go. But yeah, it's an uphill battle constantly, just like telling people what my symptoms that people are like, oh, that has no relation to endo. And I'm like, well,
it can.
it can.
Yeah.
Do you educate like your patients on some of those misconceptions that, like they might have to deal with in the future? Or I don't know.
I mean, typically it comes up. It comes up typically in the informed consent discussion, when we talk options and things like that. More often than not, it comes up in the history side of things when the patients are going over what their treatments and what their recommendations have been in the past. So, they'll say, I was told that, I'm going to go on the birth control, or they put me on birth control to prevent progression, or they put me on this hormone after surgery to kill off the rest of the disease. And
Yeah.
or they're coming to see me because they were told that the only option they have is hysterectomy to definitively treat the disease. So those things usually come up in either in the history or as we talk about options.
Okay. Can you explain just like really quickly why hysterectomy like isn't a definitive thing for endo?
So the first thing is just common sense.
Hmm.
I mean, by definition, endometriosis occurs outside the uterus.
Yeah.
So if I go in and I remove a completely normal uterus and don't treat the disease that by definition occurs outside the uterus, the disease is still there.
Yeah.
And we've removed a normal organ. So common sense tells me I didn't do anything to treat the disease.
Right.
Some will say, well, if you remove the ovaries with the uterus, then that makes the endometriosis dry up or go away. I mean, endometriosis is a tissue disease. It is hormone responsive, but it is an actual cellular tissue disease. And removing the ovaries or removing the uterus doesn't magically make those cells disappear.
Hmm.
So they're still there. And in some patients, some of the deeper endometriosis, more aggressive endometriosis, some endometriosis implants actually have an enzyme within them that can convert testosterone to estrogen. So they have the potential of making their own estrogen supply, even if the ovaries are gone.
Wow.
Really, it just comes back down to common sense.
Yeah.
That, I mean, what makes me think the disease is magically just going to disappear by taking out other organs?
I know. Literally nothing.
Bringing up like it's a more of a morbid or scary one, but breast cancer. If a patient has metastatic breast cancer,
Hmm.
granted the cancer started in the breast, so there's disease there already, but removing the cancer or removing the breast for cancer and expecting the rest of the implants to just magically go away is ludicrous.
Hmm. Hmm. Yeah, it's already all over. So,
Yeah, endo, some patients, a hysterectomy can be helpful and some patients will choose to do that. But I think that needs to be done for uterine indications rather than endometriosis surgery needs to focus on endometriosis as its own disease first.
hmm.
Then we consider, is there a benefit or a need or a want to include hysterectomy in that?
Okay. This one, I don't really know if you'll be able to answer this because, the research is still kind of confusing. I feel like I'm constantly trying to figure out like where endo comes from, why it happens. Do
Yeah.
you have any ideas like on that? I mean, I know that we don't really
Nothing,
know.
nothing more than is shared around. I think the most likely is they're a type of cell that are just deposited in the wrong place when patients are developing in the womb.
Let's take a quick pause. I want to tell you about something that's been really, really helpful when managing pelvic pain. Have you guys heard of Octavia? It's a brand that's not only dedicated to endometriosis awareness, but was also founded by somebody with endometriosis who wanted better and wanted more natural ways to manage symptoms. One of their standout products is the Ease Please suppositories. These really tiny but mighty vaginal suppositories are made with all natural organic ingredients including 150 milligrams of broad spectrum CBD. They're designed to target pelvic pain and inflammation right at the source. What I love most is how clean and intentional these are. There's no fragrances, there's no fillers, and there's really no harsh chemicals. Just science-backed, plant-based relief that feels like it was made for people like us. And if you're ready to try something that can help ease through the tough days, visit heyoctavia.com and use code CHRONICLES for a discount. That's heyoctavia, HEYOCTAVIA.com, and use code CHRONICLES for a discount. Because managing pelvic pain shouldn't mean compromising on what you put in your body.
That being said, I mean, the problem is that, looking at some of the other options, we know that retrograde menstruation happens. That's been documented, that there's been backflow.
Mm-hmm.
But to absolutely pin that to the formation of endometriosis, I don't know if that's definitively been shown yet.
Yeah.
I have seen cases. There are two that I can remember that these are patients that both had second look laparoscopies, where I did go back into surgery and I could see an area. I can see usually I can see the margins of an area that I had already removed.
Mm-hmm.
And these two patients did have a brand new implant growing on the new lining that had developed and recovered after that original surgery. Now, the origin of where that came from, Dr. Redwine would say that it was stem cell activation, inflammatory some sort of, stem cell activation from the surgery. Some people would say that was retrograde. But the interesting thing about retrograde is I would think that in patients who have already demonstrated endometriosis, so we know that endometriosis has been there from surgical intervention. If endometriosis was from retrograde menstruation, I would expect that nearly 100% of those patients would have recurrent disease.
Yeah.
Because they're already, I don't know if genetic is the right one, but they're already kind of predisposed to forming endo because we know that's their history.
Mm-hmm.
Don't see that. It's actually very uncommon to find new endometriosis in areas that have already been excised.
Interesting. I know. Endo is just like, it's so fascinating that it just grows. Like, yeah. I just...
and honestly, I think as we get to know more about endometriosis, there are so many varied presentations.
Yeah.
I think that it is going to be a collection of potentially different diseases. Some of the thicker, deeper disease behaves a lot more like adenomyosis within the uterus. It has more of a stromal or fibrotic appearance to it. And then we have other patients where it just stays superficial. Mm-hmm. I had one patient in particular that the entire pelvic lining from the kind of the hips down completely covered with endometriosis, and not a single bit of it was deep.
Wow.
So there are a lot of different presentations on how the disease looks, how it behaves, what it does, the structure of the disease. It would not surprise me if it's basically a collection of different forms of a similar disease.
Yeah, honestly, that's a really good point because it's just so complex and so different in everybody. And I'm like, how can one thing be so different? Yeah, and the symptoms are just so widespread. Like one of my good friends has endo, and she has a lot of like sciatic nerve, like lower leg pain that I never would have thought had anything to do with endo, but it can.
Yeah.
So for people who may require multiple surgeries, how would you minimize risk to other organs, or I guess just general? Is there risk to doing multiple surgeries for endo?
I mean, the main risk, I guess it depends on what's been done in the past. I think one of the biggest things that we're learning more about is going in and doing repeat excisions. It's more nerve related than anything. And this gets to deep disease down in the cul-de-sac area. So behind the cervix, in the tissues to the side of the bowel.
Okay.
There are a lot of important kind of functional nerves that go in that area. We talked about the hypogastric nerve already behind the uterosacral ligament. Those branches go up around the bladder. If we have repeat big excisions in that area, big dissections in that area, each time we go in, there's a potential of damaging nerves.
Okay.
That can result in changes in bowel function. It can result in changes of bladder function, potential sexual response, those sorts of things. So we're learning more and more about the importance of the nerve input to those areas and focusing more on nerve sparing approaches. Anytime we go cut, the tissue that heals is never as soft and supple as native tissue. So
Okay.
even though organs may not stick together, often the area that was excised, the tissue that's there, can have a little bit more of a tight or taut or fibrotic appearance or nature to the tissue than the native tissue was.
So if people have, organs that are stuck together,
Mhm.
I guess like at what point does that really start causing issues? Like, can you just leave it? Or,
Some patients do. As long as it's not causing bowel obstruction or organ damage,
Mhm,
there's no medically urgent need to go in and separate everything out.
mhm.
Now, there is a potential that it can be a source of pain, so that comes into the picture as well. Certainly, if there's functional issues of the bladder or the bowel or the ureters, those sorts of things, then you would want to get it taken care of. But if it's not causing any drastic medical issues and pain is manageable from it,
Mhm.
hard pressed to say they have to go in and take care of it. It's certainly an option to, but
Okay. For people that may not want to have surgeries, what are the most like effective non-surgical options that you recommend?
I just go over the basics. Certainly, hormones come into the discussion. I lump all hormones together, whether it's birth control, progesterone only, implants,
Mm-hmm.
injections, medicines that put them into menopause.
Mm-hmm.
The only proven role those medicines have is for symptom control.
Yeah.
So, you look at every study, even though they're promoted as treatments for endometriosis, all the studies say endometriosis related pain. And
Oh, yeah, that's a good point.
there's a big difference between treating endometriosis and treating endometriosis related pain.
Yeah.
But all the, hormones, head-to-head studies, birth control pills have been studied against Lupron. They're both found equally effective. The Mirena IUD or progesterone IUD tested against Lupron, found to be equally effective. There was one study, the only one I'm aware of, comparing Orlissa to some of the more traditional medicines. It was looked at the Depo-Provera shot, primarily for osteoporosis risk or weak bones, but they also looked at pain outcome as a secondary outcome. And the Orlissa did not perform any better than the Depo-Provera did. So really, all the studies that I'm aware of essentially say that all the hormones work about equally well. Now, patients will respond to different ones differently. So there's a lot of what we call hormone shopping, just trying to find something that helps a patient.
Mm-hmm.
Other things that can be helpful, physical therapy can be helpful. Simple low risk things, acupuncture, acupressure, chiropractic, certainly dietary changes, decreasing the overall body inflammation side of things, particularly from supplements, omega-3s, turmeric, magnesium. Those are things that can be anti-inflammatory type supplements. And most of those kind of secondary things are really, they don't help all patients, but they help some. But there's really not a whole lot of risk in trying them either.
Okay.
So,
So when you, for example, like if you're on a birth control, like I've been on the Mirena IUD for, this is my third one. So I haven't had an actual period in like 10 years.
yeah,
I mean, in reality, like that's just treating symptoms. So like the endometriosis can still be growing in the
yes,
background.
yeah.
I don't know. Is there like a risk to that? We're just mitigating. I mean, it's just,
I
I
mean,
don't know.
the main potential risk could it be progressing to the point that it's causing organ damage or dysfunction?
Hmm.
If symptoms are controlled and it's not creating that, again, then it could be completely fine for a patient to choose to stick with what you're doing. On the flip side is, and it's hard to progress because all endometriosis doesn't progress and all endometriosis doesn't progress at the same rate.
Hmm.
But in general, surgically, endometriosis is easier to treat the earlier we get to it.
Yeah.
So, if it never ends up causing an issue, I mean, you may be on an IUD
Yeah.
for longer. But it's also just, it's hard to predict because some patients have either chosen to not do surgery, or I had one patient where when I was in Utah before, we knew there was a bowel mass, find a bowel surgeon to do the resection on it. And then a few years down the road, she ended up obstructing and had an emergency surgery, completely changed the treatment, completely changed the approach to surgery. So sometimes they're hard to predict.
Yeah.
And that's what makes it hard. I mean, endo's hard because you just don't know what it's going to do in the future.
Yeah, you just don't know. I also have factor V Leiden, so like I'm not supposed to be on most hormonal birth controls. I think Mirena was fine.
Okay. Yeah, Mirena is specifically safer than the estrogen-based ones.
Yeah, but that being said, I've read some research that, and correct me if I'm wrong, because I mean, you know a lot more than I do. I've been reading recently that a lot of people with endo have estrogen dominance. Like, what does that even, have you seen that? What does that even mean?
I mean, basically, because we know endometriosis stimulates gland proliferation. Endometriosis is a tissue combined of glandular cells as well as stromal cells are kind of like the framework, the just normal tissue support for the glands. And estrogen stimulates the glandular proliferation of endometriosis.
Okay.
So in patients that don't have, they either have really high estrogen or they have low progesterone or low progesterone receptors, they become what we call estrogen dominant. Patients with PCOS have very high constant levels of estrogen that just kind of feeds and stimulates the proliferative side of the disease. And that's essentially what the estrogen dominance means.
Okay. But not everybody with endo would have that.
Not necessarily.
How would you even figure out if you had that? Is that a blood test or?
Typically blood test. The hard part with hormone-based blood tests is they fluctuate up and down all the time. I mean, even in the course of a day. You know, certainly throughout the month, they're higher levels at times than others, but even sometimes through the course of a day, they can be at varied levels.
Yeah. Interesting. Yeah, I that has been in a lot of things recently, is that the estrogen dominance, but a lot of the research is like, oh, well, that's the main thing behind endo.
It's important to realize too, though, the estrogen dominance does not create the endometriosis. The estrogen dominance can stimulate the proliferation of the glands, but it doesn't create new endometriosis. So the tissue disease, disease level the disease at tissue level is its own disease, and then it responds to various hormone influences.
Gotcha. Okay. Last couple of questions for you. I want to talk about lifestyle and like long-term management. So a lot of people with endo also have comorbidities like IBS, PCOS, mast cell activation syndrome. Have a lot of friends that have that as well. So, I mean, in reality, what I feel like the root for all of that is just like inflammation. So is that like kind of what people should focus on treating in the long term, is figuring out? The problem too is that like inflammation is so hard to treat, and inflammation can be good for things too. Like you need a little bit of inflammation for pregnancy. You need a little bit of inflammation for illnesses. So I guess like what's good and what's bad? How do you even focus on treating that?
Yeah. And I mean, really, it's one of those things that's kind of chicken and egg type of two.
Yeah.
You know, certainly we see a lot of different whole inflammatory conditions throughout the body, certainly in endometriosis patients. Anything that causes inflammation anywhere in the body. We call them inflammatory markers. They're basically just chemicals, cytokines, things like that get into the bloodstream, and those go throughout the whole body and potentially have an inflammatory effect on the body. Endometriosis causes that. Mast cell activation is where, the mast cells release their histamines inappropriately, choose PCOS, I don't know if that's, particularly a high inflammatory type of disease. It's more of a hormone malfunction of the ovary, but it's tied to insulin resistance in many cases. But I think the idea behind focusing on inflammation is really just to decrease the overall inflammatory load in the body. I mean, we hear people often say that endometriosis is a whole body inflammatory disease. I think that's a little bit off. I would characterize it as a disease that causes whole body inflammation. I mean,
Okay.
we know that endo can be found in multiple places throughout the body, but the reality is most patients, the endometriosis is confined to the pelvis or potentially the abdominal cavity. But the disease itself does generate inflammatory markers that carry throughout the whole body and probably has a whole body effect.
Okay. Yeah.
I mean, that's where diet comes in. That's where control of mast cell activation comes in. Just, it basically just focusing on things. There's a lot of, I wouldn't say, it's certainly not Western medicine, but holistic naturopathic type of things, Asian medicine, that would use, varied techniques to try to decrease the inflammatory load on the body as well.
Yeah, there's a lot of teas and a whole bunch of things that I have been trying. When I was in grad school, I probably was just like naturally more inflamed because I was incredibly stressed. So, I mean, trying to figure out how to like bring down your stress levels too and all of that stuff is just, it's all a lot easier said than done. Okay. And then I guess my last question for you is kind of like looking forward. Is there anything that you like future research or innovations that you're kind of excited for that might be on the horizon or?
Right now it's kind of current. For me, the thing that has been the biggest change in endometriosis care, and it doesn't give us any insight in the disease or origins or treatments, but that whole idea of staging endometriosis with ultrasound, to me, I hate to say game changing, but it's pretty significant.
Yeah.
Just before, I'd get a young patient and say, look, statistically, your disease is probably not too bad. I don't know for sure. There's a chance that it could get really bad over time, but the only way we would ever know that is if they had a surgery.
Yeah.
Now, with being able to pretty accurately stage the disease with ultrasound and having the opportunity to monitor it, basically just if a patient does choose to just observe or to use hormones or palliate, control the symptoms of the disease, they can do that understanding that we can now monitor it without surgery.
Okay.
Well, to me, the called ultrasound-based endometriosis scoring system really has opened up a lot of peace is an accurate word, peace of mind, knowing that this is not going to be an unknown entity, that if it does start to change or progress over time, we can catch that and then act on it if need be. There are a couple places, I think, gathering actually genetic databases of endometriosis implants. The one I'm most familiar with is out of UCLA, where they're gathering just multiple endometriosis tissue specimens, and they're extracting DNA and creating a DNA database to try to gather information about the disease and different types of disease to just see what we can learn from it. Ideally there could be targeted therapies. I know like cancers right now, they have immunotherapies where they can take a biopsy of the cancer and actually tailor a chemotherapeutic drug to only attack the cancer cells.
Yeah, that's super cool.
God, it would be amazing if they could develop that for endo. Time will tell if we're able to do that, just because there's such a variety in the endometriosis tissue itself, as well as a lot of, there's a lot of receptors and markers that are common throughout the body. But to keep something like this, we need to have it very focal or very isolated to the disease tissue itself and minimize the attacking of normal tissue.
Yeah. Interesting. And really quick, like going back to the staging with the ultrasound, is that like, do you know if that's something that's getting widely taught Or because
It-
honestly, I haven't heard about
yeah,
that prior to talking
it
to
is
you.
getting taught, but it is still very,
Hmm.
its infancy as far as people knowing about it. Most places and most people jump to MRI.
Yeah.
I mean, MRI can be good for deep disease, nodular disease. I think ultrasound is far better at picking up adhesions.
Yeah.
Just because, I mean, MRI, you have to be completely still. They can see signs of tissue tethering or absence of fat, tissue planes, fatty planes. But with
Hmm.
ultrasound, you're watching stuff move or not move.
Hmm.
I mean, MRI, if I see a patient and I'm doing MRI, I see them in the office, we have to order the MRI, we have to get approval from insurance, we then schedule the MRI. They do
Hmm.
the MRI, then the report gets back to me and I have to trust that the radiologist knows what they're looking for, and often they don't. Often MRIs are either undercalled or they're severely overcalled. Whereas with ultrasound, I do mine in my office. So during the consult, we do the physical exam. If it's appropriate, we do the ultrasound. I have immediate feedback. So we
Yeah.
directly from the history to the exam, get the information for the ultrasound, and we can sit down and talk about everything at the same visit. And just efficiency, what I can glean from it, it just, for me in my practice, it's been game changing.
Yeah. That's amazing. And I know that like,
And it's way cheaper than an MRI.
yeah, way cheaper and way faster. And it sounds like it really can be hard too, because if you have a physician that may not be like trained to look for those things, like it can for sure get missed.
Yeah.
But I mean, it sounds like maybe people are knowing.
Honestly, if doctors even just had an idea of what to look for on their
Mhm.
ultrasound or the text, it is really not hard to do.
Yeah,
If they just would stop and think, okay, what am I looking at and how are things moving? It is super easy to learn.
interesting. And I feel like that, I mean, like speaking from personal experience, I went through like countless doctors and scans and MRIs and all of these things. And even like being told, oh, they look fine.
Yeah,
There's kind of, there were, I got my gallbladder taken out when I was 15, and my endo surgeon, well, she was my gyno, but she did my endo surgery. She came back and she was like, I wonder if that had something to do with your endo. Like you
yeah.
apparently started having symptoms when you were pretty young. And I'm like, yeah, I don't know. I guess we'll never know.
I mean, you mentioned IBS before. I mean, we see
Hmm.
patients diagnosed with IBS all the time.
Yeah.
And it's more related to just the endometriosis disease around the bowel and around the nerves than it is true IBS. I think that they need to add a classification to IBS and call it IBS-E.
Yeah,
I
that's a good
think
idea.
there's a lot of IBS that's actually endometriosis related.
Yeah, a lot of it. And I actually, one of my really good friends, I know so many people that have endo now from the podcast, really.
Yeah.
But one of my good friends got diagnosed with IBS and had IBS for years. And then finally, I was like, your symptoms sound a lot like mine. Like you
Yeah.
should, and she went in and got surgery and she had endo. And they were like, oh, yeah, you actually like don't really have
Yeah.
IBS. So
Yeah. Yep.
interesting. Okay, well, to wrap up, is there anything else that you want to say before we go, or
I don't think so. You've covered stuff really well.
thank you. Thank you so much for coming on. I feel like this is really informative and hopefully everybody got some more answers on surgery and
Yeah, and
yeah.
really just, my big thing is, as a surgeon, again, it's not my role to make the decision for the patient.
Hmm.
My role is to educate, and whether the patient is 13 or whether the patient is 55. My role is to teach them what we think is going on, gather as much information as we can, and then
Hmm.
each patient gets to make their own decision on treatment based
Yeah.
on what their goals are, what their concerns are, what their hopes are, that sort of stuff. So
Yeah.
it doesn't matter to me whether the patient's 13 or 55. Every patient should have an option between, just monitoring, symptom control, or surgery, depending on what their goals and worries are. So patient autonomy is patient autonomy and informed consent in endometriosis care is severely lacking.
Hmm.
That is a major problem with the OBGYN community as they interact with
Yeah.
endometriosis patients.
Yeah, that's so important. Thank you. Thank you so much for
You're
doing
welcome.
such good work.
Okay, awesome.
Thank you so much for tuning into this conversation. If you found this episode helpful, please share it with others who might benefit from it. And don't forget to rate and review this podcast so we can continue to grow this community. I would love to hear from you as well. Feel free to message me on Instagram at Chronic Chronicles Pod, or you can email me at thechronicchroniclespod@gmail.com. I'm always happy to hear from you guys, answer questions, communicate, and I would love to hear feedback on what you think we're doing well and maybe not doing so well for the podcast. As always, take care of yourself and we'll talk soon.